Aline, I don't know if you hear my orientations, but I cannot see the chat during the presentation. So I will ask you to write down the questions on
Oh,
chat, and I see at the end,
thank
or
you.
you can take note about your questions and you talk at the end. Okay?
Yes, sure.
Okay,
Thanks.
let's start. Very good to have you here. So, I have been working with OccluSense since 2019, and today I'm totally in digital flow, okay? And I have mixed all these tools in order to make occlusal analysis and to make good good final rehabilitations adjustments. And so I will show you a little bit about what I'm doing on my clinic, my daily clinic. Let's start. First of all, we need to understand how OccluSense works. This is very important to understand. The mechanism that this device capture the information and how interpret this data. This is very, very important. So we have the hardware with these pins that connect here with the sensor, and the sensor is the core of the device, and we have the electrodes between two sheets of paper to capture this information. And all this data are transferred and processed by the app that is installed in an iPad. So let's understand how it works. It's a very, very thin sensor when we think that we have two sheets of papers coated with transferable colors. And all these systems with many electrodes between the sheets, we can see here the system from the electrodes. And all these systems has 60 micrometers. This is very, very thin for so complex and so many things together. And these electrodes here, they have 118 points sensible to pressure. And how it works, normally when we talk about pressure, we think in newtons, the pressure. And here we have a different way to capture this pressure. It's about the interruption of the electric current. So when we have current passing through these electrodes, and when we have a contact beginning or happening, we have the intensity of the interruption of this current. And this is interpreted as a pressure. For this reason, we don't have this data measured in newtons, since in ohms that is about electric current. Okay, and each of these sensible points can provide us 256 different levels of pressure, of interruption. And this is a lot of information. If we think that we have many contacts, many possible contact surfaces in the mouth, and different many points with different pressures, we have a lot of data. And if we don't know how to analyze and to interpret this data, it's so confused. So for this reason, I start this class reviewing how we look to this data. And this sensor is flexible. It's very important when we started to use a new sensor that we modeling this sensor first to initiate the capture, because it's a sheet that needs to modeling the anatomy of the occlusal surface to have more precision of this data. So we we use this flexibility to modeling for individual anatomy occlusion for each patient. This is very important. And how the system process this data? We need to understand what means each one of these many data that we receive. Let's start with the colors. The colors of the columns of the dots, each color represents a surface. This is really, really important because we think that color, it's the intensity. It's about what is danger or what is undesirable contact, and it's not. The color, it's about the size of the contact. So when I have red, I have a more punctual contact. So I can have a contact on this way, just punctual, or I can have a contact in a surface, in a large surface. This is represented by colors, by the colors, okay? So in dentistry, when we think about an ideal occlusion contact, what we are looking for? We are looking for punctual contacts, not surface contacts, okay? So on this way, we are looking for in an ideal distribution of the contacts, red columns, okay? What means the green colors, the green columns? This means that we have a larger surface. For example, when I have a wear tooth for acid, I have more green contacts. So in one extreme, we have the greens that are the most large surface, and the other side, we have the red contacts that are more punctual, okay? After understand the colors that are very important, because when we receive these so many data, these smaller columns, what they represent. Remember that I explained that when we use the sensor for the first time, we need to modeling this sensor with the occlusal anatomy of each patient. These small columns represent this non-contact, but this false contact, that is the contact of the sensor on this the surface, the anatomy surface that register as a contact, but it's not a really contact. But how can I know? How can I know which is a real contact, what is not? When we have the transferable colors to the mouth. When we start the registration, the contacts, the real contacts, are registered with colors in the mouth. So we can look that and we correlate this data with the graphic. This is a way to start to understand how to use so many data that we receive. And the other information that the system brings us is the intensity of these contacts. Doesn't matter if it's a punctual contact or a surface, larger surface contact. This contact have the intensity, and this is represented by the columns, the height of the columns. So here I have green, orange, yellow, and red columns with the same intention. Okay, it's completely possible to have a large surface with a high intensity. Okay, this is really, really important, because when I decided to use filters, I needed to understand what I'm cleaning. What is this? These lower columns are remember that we can register from 256 different intensities of pressures. These are lower pressures that are not contact, are only the contact of the sensor between the teeth, but not real contact. And I can clean this image using the filter on the right side of the screen and on iPad. Okay, so after understand how we let's come back, and the system show us a little bit more information about the balance between these contacts that are registered. The system divide in quadrants in 4 regions and show us the balance between the sides, these regions. If I look here, I have more contacts and more intensity here, and I have more intensity located in this place, in this region of the mouth. And when the same, when I have green, I have the balanced distribution. When I have red color, I have a concentration of intensity on this region that is red. So for an ideal distribution, we have punctual contacts represented by red columns in the same intensity. We have more a punctual distribution with some contacts. We will see this representation in some cases. And in this graphic, in this pizza graphic, we have all these regions in green. This is an ideal representation of the occlusion. Starting from this reference, we can understand what is happening in a real occlusion, because normally we don't receive a patient with an ideal occlusion. For other side, we receive patients that are needing, that are looking for a balance. So we have to have in mind what is an ideal design to reach that with our treatment. So when we understand these, we can we need to move to understand the importance of occlusal contacts. This occlusal contacts distribution, they are responsible for stability of the system. This is very, very important, because we can have a stable system from 2 points, from the teeth or from the joint, the skeletal stability or teeth stability. So this relation between joints and teeth, it reflects in muscle efficient. Why? Because the same muscles attend teeth function and joint function, and all the others functions, to swallow, to speech, to showing, many other functions that are made by the same system. So this distribution, it's very, very important. And I can check this distribution with a paper, a physical paper. I can use scanners, and I can use a digital system as OccluSense. So let's understand the whole of the muscles on this function, because it's recorded by OccluSense. This is really, really important, because when I have contact teeth between the teeth, it doesn't occur if I don't have muscle activity. And OccluSense shows us this dynamic of the muscles. So all the function of the system depends on muscle activity. And this activity can be balanced or unbalanced. It depends on how is the system, how is the the teeth contacts distribution, how is the stability of this contact, how is the intensity of this contact. Many factors can influence on this muscle activity and result in balance or unbalance. What drives if this system is balanced or unbalanced? The adaptability. And this is very individual. I can have the same contact distribution for one patient and see no disorder, and I can see a completely different situation for another patient that is not able to adapt to this situation. For this reason, we don't have rules how the system must works. We need to understand how this system is working and understand if we have balance or not, and how is the adaptability of this patient for that situation. This makes our activity very complex because we need to understand each patient that comes to us. So for this reason, it's very, very important, the anamnesis. Why? Because during anamnesis, we become from this patient the symptoms. We receive from this patient the symptoms. Now, what is bringing them to us to that it's a signal for that is a signal of this unbalance of the system. And after understand many, like sleep, the quality of sleep, the pattern of breathing, pains, this discomfort, sensibility to sensibility, cracks, many things that we can mapping with during the anamnesis. We can check the result of these symptoms in clinical evaluation with the signs. This is really, really important before to start the evaluation, the clinical evaluation with any device. Because if I don't know what I'm looking for, I will not recognize what I will find. This is the maximum of the philosophy that fits very, very well to this situation. If I don't know what I want to get with OccluSense, the device will bring me so many data that I will not be able to interpret and to understand this data. So the OccluSense section start before making asks what I'm looking for. Okay, this is really, really important. And let's understand how we were trained. We were trained to use and to check the occlusal contacts with papers. And how does work papers? Let's understand. This is a 200 micrometers paper that model the occlusal anatomy, and last, a surface marked where we have contact. Look at this surface, it's large because the paper is thicker, and we have this paper from Bausch. They have a technology that I don't know if everybody knows, but they have a glue. The BK101 and BK02, they have a glue in the sheet, and this glue brings with in the paper many vesicles of colors, of tint, of ink. And so we have a thicker paper from 200 micrometers. The glue is transferred. The vesicles are split, spread, and the color, the smooth colors that is in the center, it's not because here in the center has less intensity. What happens is that it's opposite. When we have a lot of pressure, in this center, the color comes to around, and it's like to spread this ink because the pressure were greater there than around. So the right interpretation of this contact, it's okay. Here the center that it's clear, it's the most intensity contact. But when we go to the same occlusion with 100 micrometers paper, look that it modeling the teeth, and the occlusal anatomy better because it's thinner, and we have a more detail, or more which is the word, more refined contact, because I have a thinner paper that transfer this glue and this ink. So when I go to 8 micrometers, here it's a sheet, it's not a paper, it's aluminum. It's a sheet that has color, and there's no glue on these kind of papers. They use the glue from this other. We have very, very delicate contact. These are the real contact, because these represent where we have the real contact. And normally, how we use this paper? We combine 200 or 100 micrometers with 8, 12 micrometers carbon, okay? To understand, because if I have a ceramic very, very glass, with a glazed ceramic here and wet, normally we are not able to transfer the color from these thinner papers. We need the glue from the decors to transfer to get this ink from these thinner papers. Okay, so what represent these papers? These papers represent the summarize of the movement. We have everything that happened during this movement represented by colors. And when I look in the mouth, we can check a 200 micrometers with a 40 micrometers carbon. But when I look that, I ask to myself, is this contact more intense than this? Is this contact more intense than this? It's very subjective. And this, I don't know when these contacts happen. I just have a representation of the summarize of what happened during the whole movement. And our brain were trained only to look that. And when we go to OccluSense, it works in a completely different way. If I don't understand these, I'm always trying to correlate what my brain was trained with I'm finding with OccluSense, and we need to change a little bit how we look that data to understand what is happening. Okay. So, and many colleagues asked me, why do I need to have an OccluSense if I have a scanner that brings me an occlusogram and I have the contacts? And what is very, very important to understand is that they are not concurrent, they are complementary. And we will understand why. Because the scanner brings us less than a paper and less than the OccluSense. And it's useful, of course, that it's useful but we have specific situations when we use a scanner and when we use OccluSense. And my questions at the beginning, when I started to work with all this technology, was, can I rely on all this data? Can I find the same data with the different devices? And what I have perceived and I have confirmed on my clinic, it's yes, we have the same data if we know how to combine and to put all together. And here it's the software, it's an occlusion analysis, the first contact, the centric contact by software, it's a mesh mixer. This is the first contact. And when we go to the scanner, we can also get the same contact. I need to know how to do that. But if I know, I'm able to find the same information. And when I activate the occlusogram from the scanners, I have many informations that I need to understand what are the contacts that the occlusogram from scanners show me. First of all, we have to understand that the scanners, they register the contact that the scans show us. It's a frame, it's a picture from a moment. And we don't know which moment from that movement we are registering. Because we will see with OccluSense that this movement, all this movement, it's not stable, it's not static. And we have a variation of these contacts during a period of time. And when we register these contacts with scanner, we have to make a registration from one side, and we go to the other side to make this registration. And we have different 2 times for this registration, and the software make this processing and the medium data about these contacts, okay? And what is represented here, we have 2 meshes, 2 static meshes that are put together, and we don't have gonphoses, we don't have muscles when we register with the scanners. We have what is the contact? The contact, the real contact, that is the red contact here, is when the meshes are crossed between them. And the other contacts are the distance between these meshes. And so depends on the system that I'm using. For example, here we have iTero. The scale of this distance, because this is the distance of the meshes, they are very large. Why? Because this scale was designed to prosthesis space. I want to know if I have space for ceramic and not for occlusion analysis. So for occlusion analysis, I can consider maximum these 2 first colors that are red, that varies from 0 until to 0.1. It's 100 micrometers. It's a lot of space. And when I consider the orange color, I have 200 micrometers. For here, it's 400. This doesn't happen from forward yellow. We don't have this happening. So we have to pay attention on this scale. With some scanners, we can adjust this scale. This is very nice. I will show you how to do that. But with some ones, we cannot adjust it, and we are very limited with this data. So can I relate the data that I find with scanners and with OccluSense? Yes. My answer is yes, we can. We can relate it. For example, here is the first contact that is here, and the others look that the intensity is less, exactly because the distance it's lower, but we can relate to that. But the point is that I have to find during the movement of registration, during the registration of OccluSense, we need to find that frame that correspond to that occlusogram that the scanners are showing us. Exactly because the scanners give us a frame, a picture from any one moment. And the OccluSense show us the whole movement, the whole context that happened during this movement, frame by frame, different from the papers that put all this movement, all this contact together and summarize everything. Okay, here we have the patients, the contacts that we register with the scanner, and we can look for a frame that correspond to this image that we get with scanners. But when we analyze the whole movement, we can see that it doesn't happen as we see with scanners. For this reason, it's very important, and we look that these contacts are not kept for a long time. The patients need a maximum muscle activity to achieve this contact and keep that with the muscle activity. The contacts only happen with muscle activity. And if I have a patient with hyperactivity or with some disturbance, some imbalance in these muscles, I will see a reflection of these muscles on the contacts. This is really, really important because some colleagues tell me, I never get the same representation with by the occlusion distribution with that patient. If I don't understand that this is showing me that we have a muscle problem, a muscle imbalance. We try to find what we get with papers or with the scanners, we will never be able to use OccluSense. And this device, it's very, very rich and very, very useful for many decisions in during the clinical activity. So you will understand that. So this is the same patients to understand the muscle activity interference on the contact registration. This is the same patient, and where I give here the order only close, and here close with force, bite with force. And look that we have completely different patients. If I don't tell you what were the commands that I gave to this patient, and if I don't tell you that these are the same patients, you will never understand and see what is happening. Look that. It's a completely different patient, completely different. Because here I have the maximum of the force. And so knowing that, I having this information in mind, I need to go back to that beginning that I explained. If I don't know what I'm looking for, if I'm trying to find the cause of a tooth sensibility, for example, I have to understand that I need to capture different situations to understand from where it's coming the overload of force in that tooth. So it's very, very important to understand these commands that helps us to use this tool with a very drive way on the clinic. So another thing that we must have in mind is that this muscle activity, it's not static. I ask for the patient to bite with force, and this patient is able to keep there all the time. It's not. We understand when we study muscle physiology, we can understand that the fibers has it's like I don't know. Let me try to find a better word. We have a very fast activity from contraction from these fibers, but these fibers are not able to keep this contraction for a long time. The potential of the neurological information is not able to keep these contractions for a long time. And we can see that when we use OccluSense. Look that the contacts vary in their intensity because this muscle, look that, it's a dynamic registration. It's not static. We must have this always in mind, that OccluSense gives us what is happening in real time. And if we're trying to look at this data with our trained from the past with papers, we will not understand what is happening. And another thing that I must have in mind is that sometimes the colleagues tell me I cannot reproduce the same contacts with some patients. Sometimes I make the registration and I register a pattern of contacts and another pattern, and maybe this can represent that this occlusion is not stable. And for this reason, every time that I try to get what is happening, I get a different picture. And this is really, really important, because if I'm looking for some information, looking for some reliable information, I have to be able to reproduce this information. And when I have these situations, for example, this is a stable contact. The patients close, open, and close again, and open. And I have a very similar pattern of distribution. This is a stable contact. This is a stable occlusion. When I record these and open and close a completely different pattern, and open, close normally these patients, when we ask them, they say, yes, I have 2 or 3 different places to close. And this shows us, this is a very useful information about how stable is this system. And it drives us to look with more attention, with more care about this system. And another, and the last point that we must have in mind is about confuses. And when I have only teeth, I have this intrusion, this movement on the ligament. But if I'm registering only, for example, implant with teeth, with tooth, I have to remember that this implant doesn't have movement, and this will be shown by OccluSense. And sometimes we need to adjust over implant crown, and the patient close and close and close. It's always high. It's always high. Yes, because when we register with the scanners for the lab to make this over crown, and we don't take care of how we register this contact. For implants, we have to make this registration with the maximum force, because remember that when we showing, when we make force, we will not have movement from this implant. And if I don't do that, this implant will be always high, and the OccluSense will register this because I don't have movements. And I have about gum pauses, we have to consider too that if I have periodontal disease, I have less support and I have more movement. And so many of these situations we have keep in mind when we will analyze a specific patient. So different, as I said, different from the other devices that are very helpful at the clinic, but any one device gives us what OccluSense gives us. OccluSense is the only tool that we have on the clinic that show us the dynamic of occlusal movement. And so I have the initial contact, what is happening, how this movement happened, how these contacts are distributed, and sometimes or many times we can find, for example, that tooth that is sensible, it's receiving a lot of intensity during the most of the movement. At the end, all the teeth are together, but for example, in 6% of the movement, I have only that tooth with a high intensity of force during the movement. This is really, really helpful for non-balanced contact during the movements, for lateral movements. It's really, really important and really, really helpful when we know how to use this information to analyze some cases. So I will bring you some cases, how to analyze some cases and how to apply this on the clinic. Here I have what we would say that it's a perfect contact distribution, contact position of teeth with a good anatomy. And let's see what is happening, what's really happening. This is a patient with a class 1 canine relation, class 1 molar relation. To the other side, exactly equal, the same way, with a good condition, with no caries, with a good anatomy, occlusal anatomy. So, but this patient has a symptom of sensibility in these premolars. And so when I check it with the papers, I have this. It suggests that we have more intensity on these premolars, but we don't know. This is very subjective. If I show for Alina's, she will tell me something. If I show to Marise, she will tell me another perception. This is very subjective. And what took my attention on this patient is that the contacts are very large. It's not the pattern that we were trained, that our brain were trained for the ideal contacts. Now we expect more punctual contacts here and punctual contact here, and so we can check. And when activate the occlusogram from the scanner, look here, this is a trios. I can trios, medit, shining. They gives us the possibility to change this scale, and this is 100 micrometer scale. This is the maximum, and the contact, the real contact. This is really, really needed, really, really helpful to understand what is happening. If I put in 2 millimeters, it's completely crazy to try to analyze this data. Okay, it's a lot of data that are not useful for occlusal analysis. So when I activate the occlusogram from the scanner, I register the same what I saw with the papers: large contacts, a good distribution, yes, but large contacts. But I still knowing if this, I still don't know how is the intensity between these contacts. And I don't have this answer with any other, any of these device that I'm using. And here we have the carbons, and here also the occlusogram from scanner. So let's understand what is happening in the real with this patient. Look that if I have the maximum intercuspation, I have a good distribution. But look that the contacts are more large here in the back and more punctual in the others. But this is the maximum force. When I look how is the movement, how these contacts are reached at the end of the movement, I can look that. Open and close. Look here. Look that. Look that. That teeth that are sensible. They last for a time here. And we will see that during the movements, we have also overload here. Look that, how we have the distribution. Look that the contacts don't happen like this at the same way, at the same time. The patient needs the muscle activity to read that. And look, when I filter the data, look how it's really correspondent with what we have in occlusogram from the scanner. And here we have the specific information about the intensity. I don't have difference between the intensity of this contact, but I have more, look, I have more contacts happening here that results in more intensity back on the back, okay? It's really, really important because here I have some contacts, but here I have more concentrated, larger contacts that in some I have more intensity concentrated here. And let's understand how is the movement, lateral movement from this patient. She goes to maximum intercuspation and now to the right here. Look how long we have the non-balanced contact, and look the intensity of this contact during this movement. This patient has also a click on this side of the joint, on this left joint. This is related with this contact. It's an overload over this joint during this movement. This joint, remember that this joint, this left joint, it's the side that makes the movement for right movement, for lateral movement. And so this is very harmful for the system. And I can also have the number of the intensity of this contact. Look that, I have that. And when I go back now to the right side, and look that all the time we have the movements in group for the left side, and that premolars are also included on this movement. This is the forward. So it's very helpful to understand and to correlate with clinical data and clinical symptoms that the patients brings us. So what I wanted to show you with this case is sometimes we have a perfect teeth and distribution, but normally sometimes they are not working in a good way. And we with this data, we can plan and we can study better these situations, the causes, This patient has in centrical contacts, this premolar are the first contact, and we make a complete functional occlusal analysis to understand and to drive the treatment and the diagnosis and then the treatment that we will offer. So let's see some clinical applications for OccluSense where this device can be very helpful to us. And oral rehabilitation, are using two different moments, normally to adjust the provisional phase and for the final definitive crowns at the final phase of this adjustment. Let's see a case. Here, this patient arrived to me with a lot of sensitivity in all the teeth. She had reflux, gastric reflux, and this is an acid erosion. And a cross bite, very destroyed, and we indicated orthodontic treatment movements for this case before to start the rehabilitation. So, but it's impossible to make an orthodontic treatment with sensibility, with all this situation. So I planned a provisional phase to improve static, improve sensibility, to give more structure for the movements, and with no contacts in the anterior teeth, because I need to move these anterior teeth to a better position, but trying to give to this patient a better balance to work during the movement. So I adjusted on that way, looking that we would have movements for this case. And we finished the case. This is after orthodontic treatment with this ceramic. Here I have a mixing of ceramic and composite, milling composite. Normally I mix the materials, but we finish with this distribution, with more punctual contacts, with the same intensity between them, with a very balanced distribution between these contacts. And here is how we finish. We decided to finish to better balance the provisional phase and how we finish the final. And here it's a control of 1 year. This patient has shown 2 or 3, almost 3 years of control, and everything stable and working, no movement from the teeth. This patient is very, very well controlled and very stable. Many colleagues asking me, do you use OccluSense to make all the refine the adjustments for oral rehabilitation? No, I use papers at the first moment, because with papers I can check the good distribution of the contacts, the place, the interrelation between the teeth. This I make with the papers. I don't use OccluSense for that. It's a lot of data to make so many decisions in a dynamic way for this phase. After that, when I finish this adjustment with papers, and I'd say, okay, I would finish, if I didn't have an OccluSense, I finish here with papers. And then I started to use OccluSense to adjust the intensity of these contacts, the distribution. This is a much easier way to use OccluSense for oral rehabilitation, for the final phase where papers and where scanners are not able to show me if I have a balance. And this is really, really helpful. I never finish an oral rehabilitation without this refinement of these adjustments. And another situation that the OccluSense is very helpful, not only to help us about the distribution and intensity of the contacts, but to follow up these patients, it's for occlusal splints. So I learned a lot about muscle activity and how we can capture about this information with OccluSense using with occlusal splints. Because I can check that, for example, this is how the splint came from the lab, and here it's how I adjusted at that time zero time for the first appointment. And I know why didn't I clean this other contacts? Because I know that this patient had a hyperactive muscle activity, and using this occlusal splint, these muscles would be treated, would be cared to a better function in some days. And look that this is the same patient with no adjustment, only the change on the muscle activity. Look that I have a much better distribution of contacts only because I took care about on the muscles. And here it's the final adjustment where I don't have extra contacts. Normally we use lower occlusal splints, and for this distribution, it's what we look for. That here I have this correlation, the contacts here, the contacts, and normally this is vestibular cuspide from upper jaw here, represented here, and I wanted only the palatal cuspid from the upper teeth or over the occlusal splint. So I clean that, and I have only these contacts with a lower contact on the canines, and then the movements on the front part of the occlusal splint. And this I can use to control this patient. What is very helpful, it's sometimes we have some patients resistant to use occlusal splint, and some of them really need to use, because if they don't use occlusal splint, they will destroy the system. So it's a protection, and we can show them how they destroy and how they disadjust these contacts by the power function using the occlusal splint. And this is a very helpful educate way to show to the patient the importance of occlusal splint. And opposite to, an opposite way to some patients that are very controlled and very good after our rehabilitation, that the system is very stable. You can negotiate the use of occlusal splints because we have objective data of this control over the time. So, and now I have been receiving a different demand that are the orthodontic treatment with aligners, and we have many problems. We have having many problems with the finalization phase of this treatment, because we know that the aligners are not able to make a very good intercuspation, and we have many patients that are adult with weared teeth, with no good anatomy to reach a stabilization. So we have many challenges with aligners overcoming on our daily clinic. And so this is a case. It's not, it was treated with aligner, but we had more here. We have how we say, when this ankylosis from some teeth, and it made this case very challenging and very difficult to finalize because we didn't have movements, and you see how we finish this orthodontic movement. But here it's impossible to get a good this movement from this occlusion with this position of canines. The patient, the main reason of the patient was this static from this tooth. But we make the possible movements, and we reached a good position of these teeth, a good relation between the cuspide, what was possible, but at the end we had a very bad contact distribution, very bad. So it's an unstable case, and how an unstable orthodontic treatment can stay there. It's not long life this treatment. So we made some addings of composite, recovering the occlusal anatomy, distributing better these contacts, and getting better contacts. But at the end, we had that. Look at that. This is the maximum contact that we get. And what do you do? So I made many reanatomization of these occlusal surfaces. We negotiated the aesthetic with the patients because I had endodontic treatment with a lot of structure lost in the palatine surface, and this tooth didn't move, and we had a difference between the position of these two teeth, and this is the middle of the way of the adding composites, and we have some legs here, some like here, but it's the middle. But we have a much better contact distribution at this moment. And here is the final case with the guidance recovered, the good distribution, a very stable a distribution of the posterior contacts stabilizing this system. This is really important. I have to record that stable contact distribution when I use OccluSense with the same graphic happening during the recording. And here it's with 200 micrometers distribution of the contacts. We had some challenge in some non-desired cuspide, but we will see that this distribution, it's very stable. Look that with 100, this is what we have observed with aligners. They are not able to move the second molars, and we finish all the treatments with this contact that it's really dangerous. And now we changed some approach for our cases, orthodontic cases with aligners. But here it's the final distribution for this case. It's really it's a happiness to see that when we have when we can get this result with a lot of effort for all the team, and we have the the movements with canine guidance for the last. It's here, canine 2, canine guidance, and forward movement, and a very stable posterior occlusal context distribution. This is how we started, how we finished negotiating a little bit from the aesthetic of this this Caesar center, but with this patient, it's really stable. I saw this patient 2 months ago, and it's completely stable. So I hope to. Here are my contacts. If you have any question during using your devices in the clinic, you can contact me. I'm always available to help. And now I will check the chat and open for questions.